Welcome to the Pharmacology 2 class. Yesterday we continued studying about the corticosteroids and we have finished about the pharmacological actions of the glucocorticoids. Today we will be studying the further points in the pharmacology of the glucocorticoids. Okay, so all of this we have already done. So the most important action, pharmacological action of the glucocorticoid is the anti-inflammatory action of it. Okay. So next is the miscellaneous actions, and this is the pharmacokinetics where we left yesterday. So pharmacokinetics of the hydrocortisone and the synthetic glucocorticoids. Okay. So hydrocortisone, it is more of a analogous to that of the natural cotton glucocorticoids, and we have some purely synthetic glucocorticoids. So their pharmacokinetics, that's what we are going to study today. Okay, so the oral bioavailability of the hydrocortisone is about 50%, and it is variable, so it varies between 30 to 90% on administration as an enema. Okay, so absorption from aqueous suspension of acetate given intramuscularly is lower than that of the orally administered hydrocortisone, and hence the effect lasts longer. So acetate over here, it is acetate of the hydrocortisone and it is a salt. Okay, so we have to convert the hydrocortisone into a salt in order to give it by the intramuscular route. Okay, so as its absorption is slower from the intramuscular injection, its effect is for longer duration of time when we compare it with that of the oral administration. So next is absorption of prednisolone. It is almost complete, so like 80 to 100% after both oral and the rectal administration of. So it is worth noting that as much as that of 50% of intra-articular prednisolone administered in patients with the this rheumatoid arthritis, it is absorbed into systemic circulation. Intra-articular means what? The injection which is given directly into the joints. Okay, so in which condition we have to give injection of the prednisolone in joints in case of the rheumatoid arthritis. So out of the dose which is administered, around 50% it is absorbed in systemic circulation. Dexamethasone, it is well absorbed like 80% orally, and the bioavailability of oral methylprednisolone, it is variable. So we have discussed multiples of the drug over here. That is, the first one is the hydrocortisone, which is more of a natural, and we have synthetic drugs, that is prednisolone, then dexamethasone and the methylprednisolone. Okay, so cortisone, it acts in the body after conversion to the hydrocortisone, and prednisone to the prednisolone in the liver. Okay, so hydrocortisone, it is like the active form of it. Okay, so hydrocortisone, it is highly protein bound in the plasma, and so is the prednisolone. Dexamethasone is less protein bound than the hydrocortisone. Okay, so hydrocortisone, it is largely metabolized by conversion to tetrahydrocortisone and its conjugation. The prednisolone, it is metabolized by hydroxylation and followed by the conjugation. So adverse reactions, these are related to individual susceptibility, dosage, duration of therapy. Okay, so if we give a single large dose of the prednisolone, that is 1 to 2 milligram per kg. See, we are writing milligram per kg of the body weight. Okay, so or equivalent dose of other glucocorticoids, they are generally harmless and may therefore be used without hesitation in situations where life is threatened by adrenocortical or pituitary insufficiency or by cerebral edema. So a single large dose we can use without any problem. Okay, so short term therapy generally of 1 to 2 weeks with moderate doses is unlikely to produce any harmful effects. Then in which conditions the adverse reactions they are most evident? So it is the prolonged therapy. Okay, so the prolonged therapy with the glucocorticoids in doses higher than 20 to 30 milligram of the hydrocortisone and or equivalent doses of other steroid per day is liable to cause the adverse effect. So single large dose short term therapy has at, at such no adverse effects or very least adverse effects per se, but the prolonged therapy it produces the adverse effect or it is ought to cause the adverse effects. Okay, so hence this is generally recommended maximum maintenance dose in prolonged glucocorticoid therapy. Okay, so the only exception is life-threatening condition where doses large enough to suppress the clinical manifestations of the disease they are needed, and then one accept adverse effect as the price one has to pay for keeping the patient alive. So here we have like a situation where if we don't give large doses of the glucocorticoids, then patient will die. So if we check the benefit to risk ratio over here, although the glucocorticoids they have the adverse effects, but here if we give the large doses of the glucocorticoid, the life of the patient is going to saved. So that's why we opt for the large doses and we will care for the adverse reactions later because that can be tackled. But if the patient dies, if we don't give the glucocorticoid in large doses, then there is no use of giving the maintenance dose because dead bodies don't respond to the medications. Okay, so that's why we have to take a risk at that particular time. Okay, so on to the gastrointestinal tract. The acute erosive gastritis with hemorrhage, it may occur during intensive therapy of the with the glucocorticoids, and peptic ulceration may be troublesome during the prolonged therapy. So why peptic ulceration? We have studied that it doesn't let form the arachidonic acid, and as the arachidonic acid doesn't get formed, there is no further formation of the prostaglandins. And if you remember that one of the prostaglandin has a protective role in the gastric mucosa, that means it protects the gastric mucosa against harmful effects of the that particular gastric acid. But in case of this glucocorticoid therapy, as glucocorticoids doesn't let the prostaglandins to form, that's why this protective action of the prostaglandins it is also inhibited, and thus the mucosa, gastrointestinal mucosa, is exposed to the harmful effects of the gastric acid, and that's why there is peptic ulceration in prolonged therapy. Okay, so intestinal perforation and the pancreatitis are the other reported GI complications. So perforations means what? It is directly, there are holes that occur in the intestine. Okay, and the pancreatitis is inflammation of the pancreas. So onto the endocrine system, the glucocorticoids produce adverse effect as these are nothing but the extension of their pharmacological actions, and they comprise of the hypercortisolism, that is excess of the presence of these glucocorticoids in the body. Okay, so the metabolic effects, the clinical manifestation which include the ketoacidosis and non-ketotic hyperglycemic hyperosmolar coma of idiopathic diabetes mellitus, it can be precipitated. The pre-existing diabetes, however, is not an absolute contraindication to glucocorticoid therapy. Means what? If the if there is a patient who does not have the diabetes, then these glucocorticoids, they can induce idiopathic diabetes into such patients. But if a person already has a diabetes and we are supposed to use the glucocorticoids, then we can use it, because it won't be causing the diabetes because it is already there, and the development of the hyperglycemia during the therapy with the glucocorticoids, it doesn't warrant the stoppage of the treatment. Okay, so we should not stop the treatment uh, with the glucocorticoids if there is hyperglycemia, because the hyperglycemia, it can be tackled. Okay, so some patients, they develop hyperlipidemia and hypophosphatemia. So hyperlipidemia, excess of lipids in the body, and hypophosphatemia, that is decreased levels of phosphate. Okay, so prolonged therapy, it causes central obesity with moon face and the buffalo hump. So it is because of its action, or it causes movement or redistribution of fat from the abdominal region to the neck region and the face. Okay, so that's why moon face and the buffalo hump. So the pink florid stripe, it appears on the abdomen, hips and the pectoral regions, and the skin may become friable. Okay, so patients may get spontaneous ecchymosis and the bruise easily. So which is nothing but the Cushingoidism. Okay, so Cushing syndromes, it's classical symptoms we can say. Okay, so suppression of inflammation and the immune responses is the next adverse reaction. So the glucocorticoids may mask clinical features of serious illness. For example, fever and abdominal rigidity may be absent when the patient on this drug develop acute peritonitis, which may therefore be missed. Okay, so why this happens? Because it suppresses the immunity, and that's why the cells of immunity or cells of inflammation, their action is also suppressed. That's why we don't get to know if there is some problem with our body. Okay, so we have had discussed this in the laboratory, that whether the inflammation is essential or non-essential. So the essential function of the inflammation is to alert the body about the impending infection or the infection which is already there, it is suppressed, and that's why it is very much harmful, because we are not able to identify what is wrong with our body, and hence we don't treat it. And as we don't treat it, it is missed. It may further create the complications. Okay, so further pre-existing infection like tuberculosis, they can spread, and super infection with other organisms, it can occur. So that's why the inflammation is an essential, it becomes essential in these cases. Okay, so next is the retardation of linear growth. It occurs in children who receive high doses in equivalent therapeutic doses. Prednisolone is twice, and dexa and betamethasone is thrice as growth inhibiting as hydrocortisone. Okay, so in growing children, these drugs are to be avoided in large quantities. In certain condition, we have to give these drugs, like in case of asthma, but high doses needs to be avoided. Okay, so on cardiovascular and renal system, the hypertension, salt and water retention, and rarely hypokalemic alkalosis, it can occur. Hypokalemic means there is decreased potassium levels, and due to which the alkalosis results. Okay, alkalosis, it is uh, conversion or shifting of blood pH to the alkaline. Okay, so they are uncommon with the dexamethasone, betamethasone, and the triamcinolone. So only certain drugs, they can cause these effects, but these three drugs, they rarely cause, or they don't cause these reactions at all. So onto the CNS, the glucocorticoids, they readily enter the brain, and they can influence the mood, sleep patterns, and the EEG activity, that is electroencephalogram. Okay, so patients may complain of insomnia, that means sleeplessness. Okay, acute psychotic reactions may occur, especially during the intensive therapy. Benign intracranial hypertension, that is inside the cranium, there will be increase in the blood pressure. It can be which is non harmful, that's why the word benign. And the aggravation of epilepsy, if it is already there, particularly in children, it can occur. Then musculoskeletal effects, the proximal myopathy, osteoporosis with compression fractures of the vertebrae, they are the serious complications of this. Okay, so bisphosphonates, they are reported to prevent the osteoporosis. Okay, bisphosphonates are the drugs which are used in treatment of the osteoporosis. Okay, so if we give the bisphosphonates along with these drugs, then it will prevent the osteoporosis. So occasionally acute avascular necrosis of the bone, it may occur. So onto the eyes, the glaucoma occurs in some patient during local glucocorticoid therapy, and posterior subcapsular cataract, it has been reported during their long-term systemic use. Then it also known to cause the inhibition of HPA axis. HPA axis, this is hypothalamus, pituitary, and the adrenal gland. Okay, so whatever interconnection this hypothalamus has with that of the pituitary, and pituitary has that with the adrenal cortex or adrenal gland per se, it will be inhibited. Okay, so miscellaneous changes, these include coagulability of the blood with thromboembolic complication. Thromboembolic means the thrombus will get formed because of this hypercoagulability, and this thrombus has capability to shift from one place to the another, so that is embolism. Okay, so acne, hirsutism, it is excess of hair growth, then loss of scalp hair, then this hirsutism actually, if you see that there are two conditions we are saying, that hirsutism and the loss of scalp hair, it means that the hair growth is more onto the body rather than onto the uh, head, onto the scalp. Okay, so uh, it causes alopecia, but it causes excess of hair growth onto the body. Okay, so subcutaneous atrophy and delayed wound healing, it is also seen. So therapeutic uses, it is first and foremost used as a replacement therapy. So it is used in management of adrenocortical insufficiency, which arises from adrenal disease, that is the Addison's disease, which is primary adrenocortical insufficiency, or the hypopituitarism, which is nothing but secondary adrenocortical insufficiency. Okay, so next is second as the pharmacological therapy. As a pulse therapy, it is useful, and it is useful in threatened acute rejection of a renal graft, vision threatening Graves' exothalamus, and similar dire emergencies. Then second pharmacological use is in intensive short-term therapy. So in conditions where inflammatory responses or metabolic response of the body itself threatens the life. Okay. Then we have third, that is the cerebral edema. So useful in cerebral edema, which happens due to neoplasms, either primary or metastatic. Then fourth use in prolonged high dose suppressive therapy. So it is indicated in severe acute rheumatic fever, then severe ulcerative colitis, then coeliac disease which is not responding to gluten free diet, then subacute hepatic necrosis, then chronic active hepatitis, alcoholic hepatitis, autoimmune hemolytic anemia, idiopathic thrombocytopenic purpura, then acute lymphatic leukemia, disseminated Hodgkin's disease, then nephrotic syndrome, acute homograft rejection, then pemphigus, and the collagen diseases, which include vasculitis and the SLE. SLE stands for systemic lupus erythematosus. Okay, so if you see multiples of usage these particular drugs have. Okay, so next is in low dose for chronic palliative therapy, and it consists of use of small doses of a glucocorticoid, that is 2 to 10 milligram of prednisolone per day, as an adjunct to some other drug, for example NSAID in the rheumatoid arthritis. So the chronic suppression of the ACTH secretion, it is indicated in congenital virilizing adrenocortical hyperplasia. Okay. Next is neonatal respiratory distress syndrome, the prevention of it. So the lung maturation in the fetus, it is influenced by the fetal cortisol secretion, and this may be affected by the prematurity. That means if the baby gets born prematurely, that is usually baby should born after 9 months of the gestation period, but if baby gets born before to that, then the organs, they are in their premature stage. That means they are not mature, they are not completely developed. So to cause uh, this particular prematurity or the incomplete development of the organs, it leads to the various complications, and one of the complication is the respiratory distress syndrome. That means the neonate is not able to breathe properly. Okay, so that's why we have to give the glucocorticoid, so that this will help in the development of the lungs, neonatal lungs, and that particular neonate, that particular baby can survive and can take up that particular distress syndrome challenge. Okay, then topical application, it is valuable in many dermatological, ocular and external ear conditions. Ocular conditions benefited by the local therapy uh, consist of interstitial keratitis, then phylactenular conjunctivitis, then spring cataract, then iritis, then iridocyclitis, whereas posterior uveitis and the sympathetic ophthalmia, they need systemic medication. So earlier on they require topical one, and later ones they require systemic administration. Next is mineralocorticoids, but this point we will study in next lecture. That's all for the glucocorticoids today, and this mineralocorticoids only a very small point we will study in next lecture. Okay, so that's all from my side.